Hello, Vishnu.
Hello.
Good evening.
Good evening, sir.
Can you see the screen?
Yes, sir. Yes, sir.
Okay, so let us start.
Yes, sir. A 30-year-old female with no comorbidities came with acute onset weakness, brought carried by her husband, not able to move all four limbs on waking up in the morning, low loss of consciousness, no sensory or bladder symptoms. Similar episode of weakness 4 years back, 2019, which resolved within 2 days. Unmeasured uh, weight loss in spite of adequate food intake. No history of any other thrombotic events.
Would you like to say something now?
Uh, Acute flaccid paralysis, sir.
Acute
For
flaccid
all four limbs,
paralysis.
GBS can be possibility, sir.
Yes.
With
Any
the
other
no set,
possibility? It developed
it
overnight,
can
no?
be overnight. Can be hypokalemic periodic paralysis also, sir.
Okay. What else it can be? Can it be CVA?
Yes, sir.
All four limbs. So where do you localize them?
Any cervical lesion, sir.
Without any sensory or bladder. Cervical lesion overnight developing.
Yeah.
Can be basal artery.
It can be basilar artery thrombosis, sir. And
Okay. Okay. So why did you come to hypokalemic periodic paralysis here?
similar episodes of weakness for four
Similar
years back.
episode.
Yes,
Similar
sir.
episode. Okay. Past history.
Past history of inflammatory polyarthritis 4 years and was on HCQ stopped recently.
So, how do you diagnose polyarthritis from the history?
Um, with complaints of recurrent episodes of pain over joints,
So, can it
mul-
be osteoarthritis? Why do you say inflammatory?
inflammatory with associated with fever and
So,
tenderness over the,
rheumatoid arthritis, do you get fever?
no sir, with the tenderness of the
What,
joints.
what symptom in arthritis makes you think it is inflammatory without touching the patient? Morning stiffness that
Morning
makes the
stiffness, sir.
diagnosis.
Okay, sir.
Okay, so he had 4 years his patient on chronic inflammatory polyarthritis. Okay,
Okay, sir.
what is the polyarthritis? What's poly?
Multiple joints, sir.
How many? My
More than three, more than two.
then what is oligo?
Oligo is sorry, sir. Oligo is 2 to 4, more than four joints, sir.
Okay, five and more. Okay,
Okay, sir.
carry on. Okay,
On
examination.
examination, patient was poorly built and nourished. Pallor was present, vitals normal, no features of thyrotoxicosis.
So is
The
the
BMI of
BMI?
BMI is underweight, sir, patient.
What is the expected for Asians?
More than 19, sir. 18.5.
Okay,
Central nervous system, higher mental function normal, cranial nerves normal, coordination normal, sensory system normal, no signs of meningeal irritation. Bulk, there is no wasting. Patient has hypotonia with a power of 0 by 4 in all four limbs.
the as per the picture, you can see that neck muscles are also weak.
Okay, sir.
Flaccid.
Okay, sir. Reflexes were 1 plus with the bilateral plantar flexor. Provisional diagnosis acute flaccid
You already
quadriparesis.
said it is acute flaccid
Acute
paralysis. That's
flaccid
your
quadriparesis.
diagnosis.
Yes, sir.
So what do you want to do next?
Uh, we have to go with the investigation, sir.
So what are the investigations you plan in this case?
We can go for a CSF analysis, sir.
CSF analysis. So,
Yes,
what
sir.
is in your mind when you go for CSF study in this case?
We can in GBS there will be albuminocytological dissociation, sir.
So, day one, do you get advanced heterologic dissociation, or what's the
No,
right
sir.
time to do CSF study?
No, sir. After 1 week only, it will there will be albuminocytological
Okay,
dissociation.
so we'll wait. We'll wait. Another
Okay,
investigation
sir.
you want?
Investigation. Routine. First, electrolytes has to be taken, sir. Routine investigations.
Okay,
Complete blood count, RFT, LFT. Electrolytes has to be seen, sir.
okay, that will do. Okay, so before that, you put your differential diagnosis. You
Um,
already said.
Guillain-Barré syndrome, brainstem stroke, hypokalemic paralysis.
The problem is Guillain-Barré syndrome. Does it
Yes,
develop
sir.
full overnight,
No,
zero
sir. It is
power?
progressive only, sir.
Before motor symptoms appear, do you
Sensory.
expect any? That's right. That's
Patient will be
absent in this case, no?
giving tingling or sensations will be that.
Do you expect
Conversion reaction.
conversion reaction? What is the
Okay, sir.
conversion reaction? What's
Sir,
conversion
not,
reaction?
not sure.
Okay, what is meant by hypochondriasis?
Hypochondriasis patient will be complaining of
What's meant by somatization?
with without any involvement, organ involvement. That will be investigation will be perfectly normal, but patient will be repeatedly complaining of symptoms.
In
Uh,
hypochondriasis, patient will be concentrating on one organ, one diagnosis,
okay, sir.
like liver disease. Liver disease moves from place to place to rule out particular disease. What is somatization? Somatization is where complaints are pertaining to different parts of the body.
Okay, sir.
Headache is relieved, then comes chest pain, then goes backache. But coming to the conversion reaction, it points to only neurological problems without an organic
Sorry, sir.
basis.
Okay, sir.
Aphasia, aphonia,
Okay, sir. Okay, sir.
paralysis. So it will be a specific neurological problem.
Okay,
Okay,
sir.
so conversion reaction. So what are the cause of hypotonia? She had hypotonia, no?
Hypotonia.
So what are the
Yes,
causes?
sir. Hypotonia. In uh, state of spinal shock, there will be hypotonia, sir.
That's good. Any other?
Element weakness, element paralysis, sir.
Brilliant. Any other?
Then in hypokalemic periodic paralysis also there will be hypotonia.
That's
Metabolic
right. That's right. That's right. Metabolic causes.
metabolic causes, sir.
Yes. So cerebral disease you get specifically,
Yes, sir.
and
Spinal
one of
shock,
the extrapyramidal diseases with hypotonia is chorea.
chorea. Okay, sir.
So you wanted investigations, and
Okay,
comes
sir.
like this.
The investigation showed the hemogram was normal with a potassium of 1.6 and
What's normal potassium?
um, 3.5 to 5.5, sir.
Good. Okay.
With urea creatine normal, LFT normal, thyroid normal, and the urine routine were normal.
Your routine, the pH is 6.5.
pH is 6.5.
Okay. So what do you do next for this patient? What other investigation
Next,
you want?
with the hypokalemia and with the
What
recurrent,
investigation? What
it,
investigation you want?
we have to go for the autoimmune panel, sir. ANA has to be done, sir. Severe hypokalemia. ECG has to be taken.
So what do you expect in ECG?
ECG, there will be conduction blocks and there may
In
be
hypokalemia, what's the
UV,
earliest?
UV will be seen, sir.
UA will be seen. What else?
Um, then
So easy to remember.
okay,
Potassium
sir.
is situated just underneath the T wave. When potassium goes up, it goes up tended peaked fashion. And when
Okay,
potassium
sir.
goes down, it disappears or flat or absent T wave. So T is the one. Okay.
Okay, sir.
So you said your
Presence
U
of
wave,
UV,
you said flattening
T
or
wave
depression.
flattening or depression, QT
Then you
prolongation will be
said
there. Apparent
apparent
QT
yes.
prolongation, ST depression, PR prolongation,
Okay. So what do you want next?
ABG has to be done, sir.
Okay. Can you see it?
Yes,
Is the
sir.
screen clear?
Yes, sir. Yes,
Okay.
sir.
Okay. Yeah, yes. What do you think? You can read the important things and
Yes,
then
yes, sir.
come.
pH is of 7.25, sir. It's an acidotic side
Yes.
uh, with potassium 1.5 with the bike.
No. What after pH? What do you read next?
PCO2 is
PCO2.
found, yes, sir, 24.7, sir.
So
It's reduced.
it is
It's
not
alkalis.
respiratory.
Sir,
It
it's
is
not.
not respiratory.
PCO2 is
So
reduced.
what is next?
Alkalos, metabolic
No. 7.2 is acidosis. No.
yes, sir. Yes, sir.
Then how do
PCO2.
you
It's
alkalosis?
compensate.
Wait. So reading of
Okay, sir.
ABG, you said pH first, bicarb
Yes, sir.
next, then you
Yes,
go
sir.
to sorry, PCO2 next, then goes to bicarbonate. Where is bicarbonate?
Bicarbonate
Lower
level was
down.
13.2, sir. It's lower.
Okay, what do you think? What's normal?
24, sir. 20 to 24 range, sir.
So from this, what can you make out?
Um, there is metabolic acidosis.
Metabolic acidosis.
Yes, sir.
So
Metabolic acidosis.
what do you do next with the anion? What's anion
Com
gap? Can
anion
you get
gap
an
is
anion gap from this?
yes, sir. Yes, sir. Anion gap of 22, sir.
No. Where is sodium? 136 plus potassium 1 minus
1.5.
chloride
12, sir. 12.
12.
Yes, sir.
Okay.
Minus
So
chloride.
is it normal?
Sir, one, sir.
Is it wide anion gap or normal anion gap? Normally so much? 9 to?
13, sir.
Okay, so it's normal.
Yes, sir.
So she has acidosis. Metabolic, you said the reason you said.
Acidosis
Is
with
it
the compensation is
compensated?
there. Yes, sir. Yes, sir. Respiratory compensation is there.
But how do you know that?
PCO2 has been, both are on the same direction, sir.
Washed out, eh?
PCO2
PCO2 is
also
washed
red.
out. Washed out.
Yes,
So
yes,
is
sir.
it completely compensated?
Um, for for every one bicarb, there should be.
No.
Okay, sir.
If it is completely compensated, pH must be normal, no?
Yes, sir. Yes, sir. Not completely compensated.
It's partially.
Partial compensation.
Anion gap is
Normal anion gap, sir.
normal anion gap. So what do you think? So what are the causes of wide anion gap and what are the causes of normal anion gap?
Normal anion
Acidosis?
gap, renal tubular acidosis, sir.
Yes, any other?
In GA losses, sir.
J losses, you get acidosis, eh?
Uh, Normal anion gap, maybe.
Diarrhea, I mean.
Yes, sir. Diarrhea and vomiting, sir.
Yes,
Diarrhea,
what
mainly
else?
diarrhea.
What else?
Then
Any drug you can think about?
drug,
Any diuretic you can think about?
furosemide, sir. Last,
No. Used in
spironolactone.
used in ophthalmology also.
The acetazolamide, sir.
What about post-surgical situations? in any post-surgery situation where you can have this picture? Any urological procedures?
Yes, sir. TARP, the prostate
No,
surgery, sir.
no. Bladder carcinoma, where
Sig
you reimplant the
sigmoidus,
ureterosigmoidostomy.
ureterosigmoidostomy, sir.
Okay, that's okay, fine. So normal gap metabolic acidosis. So high anion gap acidosis, what are the causes?
Sir, uh, lactic acidosis,
Yes,
uh, uh, diabetic ketoacidosis,
yes.
then with the methanol and ethylene glycol poisoning, there's those cases.
Methanol, okay.
Then,
Uremia,
yes, sir, uremia, in uremia, sir.
sepsis,
Sepsis also, sir.
salicylates.
Yes, sir, salicylate.
Okay. So we have wide variety of causes.
Yes,
So
sir.
high anion gap metabolic acidosis. What is the delta sign?
Delta sign is, sir, I forgot, sir. Not,
Okay. Coming back to the mode of normal anion gap acidosis, how does it occur? Excess
sir.
loss of bicarbonate.
Yes, sir, excess loss of bicarbonate will be there.
So which all routes?
Through renal route, sir. Mostly by renal route, sir.
Or GI loss also, no?
Or GI loss. Yes, sir.
How many types of renal tuberculosis are there?
Four types are there, sir.
Fine. So summarizing, we have got
Summary,
inflammatory polyarthritis here with
acute
acute
flaccid paralysis,
flaccid paralysis,
severe
severe
hypokalemia,
hypokalemia,
normal anion gap
normal
metabolic
anion gap
acidosis.
acidosis.
Yes, sir.
So what can be
Uh,
the reason?
Sir, it can be because of the renal tubular associated with Sjogren syndrome, sir.
So what type of renal tuberculosis your patient is having?
Mm. Renal tubular type 1, sir.
Why do you say so?
Because the urine pH was 6.5, sir.
That's good. That's good. So,
Uh, uh,
this is type one. Type one.
yes, yes, sir.
Type one is proximal or distal?
Type 1 is proximal, sir.
Type one is distal. Huh?
Yeah, okay, sir.
So what are the causes of type one?
Uh, Type 1, it can be because of uh, thiazide. It behaves like thiazide diuretics, sir.
So any etiologies can you postulate for type one RTA?
Sir,
No.
lead Bartus, Sjogren's, SLE, and rheumatoid.
So how will you recognize Jogren in the bedside?
Um, Sjogren, we have
Through
to,
symptoms.
yes, sir, symptoms.
Through what symptoms you ask for?
Whether there is any dryness of eyes or oral mucosa, sir.
Okay, that's fine. That's fine. So two questions will be helpful.
Yes, sir. Then
Other causes?
congenital medullary sponge kidney, metabolic
Okay.
hypercalcemia, drugs like amphotericin, lithium, and ibuprofen. Other causes: sickle cell anemia, hyperparaproteinemia, obstructive uropathy.
So how to proceed now?
How to proceed?
You have postulated it is a
We have to,
hypokalemic period where
with
yes.
the renal tubular acidosis type 1, we have to go with the autoimmune panel. ANA has to be done, sir.
Any other simple techniques to
Lib, lib biopsy.
lip biopsy? Okay. Zika symptoms were present. So what do you find
Yes, sir.
here?
That the dryness
Caries
of
tooth.
Caries tooth is there, sir.
Okay, so dental caries is present. Any other test can you do on the bedside?
Swimmer test for lacrimation, you have to.
Yes. So what paper is used here? Filter paper. And
Okay,
how
sir.
long you wait? 5 minutes.
Five
And the
minutes,
result
sir.
was positive in this case.
Okay, sir.
So that is consistent with the
Uh,
diagnosis of
jog, dryness of eyes, sir.
dryness of the mouth.
Okay,
So
sir.
what do you do next? Anyway, so you got something like iceberg here. The tip
Yes,
of the
sir.
iceberg you got first flaccid paralysis,
Yes.
then you find hyperkalemic paralysis, normal anion gap
And
metabolic
get metabolic
acidosis,
acidosis, renal type
and then
1,
you
renal
went
tubular.
for renal acidosis, and then you
Yes, sir.
came to the clinical bedside diagnosis of Sjogren
Jogren syndrome.
syndrome. We have not done lip biopsy, so these are final diagnoses here. So
Okay,
what are the
sir.
investigations you want for Sjogren syndrome?
Hmm. We have to go for uh, uh, the ANA and SS, ANA profile has to be done, sir. And also lip
SSA and
biopsy.
SSB.
Yes, sir. SSA,
Okay,
SSB,
lip biopsy not
lip
mandatory,
biopsy.
can be done.
Okay, sir.
Okay, so Sjogren syndrome has to be thought of. So how are you
Yes,
going
sir.
to treat this acute flaccid paralysis?
It can
You have to supplement potassium
what supplement potassium has to be given, sir.
and patient recovered. Then how are you going to take care of the renal acidosis to prevent it?
Uh,
What will you give?
Bicarbonate supplementation has to be given.
Potassium citrate
Potassium citrate has to be.
has to be given. Okay.
No,
And how
okay,
are you
sir.
going to take care of this Sjogren syndrome?
Uh, has to be started on uh, steroids and
Now you can go
uh,
for
HCQ.
hydroxychloroquine,
HCQ has to be.
and subsequently you can go for methotrexate if you want,
Okay, sir.
and follow up the patient to look for complications coming time again.
Okay, sir.
Can it lead on to some malignancy?
Um, Lymphoma, sir.
How will you recognize it? Means who are the candidates who gets lymphoma early? If you find globulin is high, if you find
Okay.
their parotid enlargement, if you
Yes,
think
sir.
C3, C4 are low, then these
Okay,
are the
sir.
candidates who may go for.
Lymphomas.
Okay. Is Sjogren syndrome very rare?
No, sir. Common.
Primary Sjogren syndrome is common. Okay. And
Uh,
then what's the commonest cause of renal tubular acidosis in India? The commonest cause is again Sjogren syndrome.
okay, sir.
Okay.
Okay,
So
sir.
you have done a wonderful discussion today.
Thank you, sir.
You picked up everything.
Okay,
Acute
sir.
flaccid paralysis, present with hypokalemic periodic paralysis. Do you have any doubt to ask?
Uh, Sir,
Couple of things you may
why,
read.
sir, why is there any why that renal tubular why the organ is affecting that renal anything
That
particular,
is
sir?
the pattern presentation of different
Okay, sir.
diseases affecting different parts of the body.
Okay, sir.
One
Okay, sir.
only thing is you didn't ask me. The
Okay, sir.
hypokalemic periodic paralysis, you expect the reflexes to be lost.
Yes, sir.
In our patient, it was not
No, it's
lost.
one plus.
It was
Yes, sir.
there.
Ah, yes,
And
sir.
I don't have any explanation, but
Okay, sir.
uh, that was what we saw here.
Okay, sir.
So how often you have seen this type of cases
Sir, when I was IC duty, I have seen two cases, sir. Ward also around this 3 years, I have seen around four cases, sir.
of hypokalemic periodic paralysis?
Yes, sir. Yes, sir. For hypokalemic periodic arrest,
And
of which two turns to be Sjogren, sir.
very good. And anybody turned out to be thyroid disease,
Ah, yes, sir. One turned out to be hyperthyroidism, sir.
hyperthyroidism. Okay. So very nice of you. Thank you.
No, thank you, sir.
When are you free next?
Sir, Only Tuesday, Wednesdays I will be having duty, sir. Other days I will be free, sir.
Tomorrow you are free actually, no?
Tomorrow free only, sir.
Let me see what can I do.
Okay, sir.
Thank you, Vishnu. It's long time.
Okay, sir. Okay, sir.
You
Thank
are
you, sir.
fine there, no?
Yes, sir.
We had
Fine,
a
yes,
good
sir.
discussion.
Thank you, sir.
Delta sign you have to read. Delta sign you have to
Okay.
read, eh?
Okay, sir. Okay, sir.
A
I
couple of
just
things.
forgot, sir.
Otherwise, you
Okay,
read
sir.